Hello and welcome. We are going to have a Screenside chat with Dr. Laya Ekhlaspour. My name is Marissa Town. I am the clinical director for children with diabetes. I am a nurse and a diabetes educator, and I've been living with type 1 for 31 years. And I'm going to go ahead and introduce Laya. And I had the joy of working alongside Laya at Stanford for the last few years, aside from the pandemic, and I'm looking forward to seeing her again in person at some point. And Laya is a pediatric endocrinologist, and her training and expertise are in the clinical care of diabetes and diabetes research. During her residency, she was inspired by seeing the use of novel methods in the management of diabetes while attending diabetes summer camps and decided to focus her research efforts on type 1 diabetes. During her fellowship in pediatric endocrinology at the Massachusetts General Hospital, she focused on diabetes technology and specifically on automated glycemic regulation with the bionic pancreas. She joined Stanford's closed-loop research team in 2016 and continues to apply her evidence-based clinical knowledge to develop and test technology-driven tools to improve the management of diabetes. And she has collaborated with several groups, developing different artificial pancreas systems, continuous glucose monitors, and has been co-investigator of pivotal trials of current FDA-approved systems. May or may not have worked on her with those, and as well as some that are still in the process of clearance. And she also received an NIH grant specifically to address problems related to providing adequate insulin coverage for meals that have variable fat and protein content, which is what we're going to talk about today. Welcome, Laya.
Thank you so much, Marissa, for this kind introduction, and thank you for the opportunity. I really hope you find this talk helpful. So I am going to share my screen with you.
Yes, and I'm going to turn off my camera for the part where Laya is presenting her slides. And if anyone that is signed on would like to post a question in the chat or the Q&A feature, please feel free to do so, and we will go through the Q&A at the end of the presentation.
Okay, are we good here? Do you see my screen?
Yes.
Thank you. Thanks, Marissa. These are my disclosures. So today we are going to talk about how fat and protein impacts blood sugars. We will talk about how they affect blood sugars after meals in patients with type 1 diabetes. We will also review the evidence on some dosing strategies for foods with high fat and high protein in patients with type 1 diabetes. And at the end, we talk about how current closed loop system handle post-meal blood sugars. And we will mention some critiques in this area and what future work basically is needed. So based on ISPAD and ADA guidelines, post-meal glucose level is recommended to be less than 180 milligram per deciliters. And as continuous glucose monitors become standard of care in patients with type 1 diabetes, we really hope that this goal is more feasible. But we know it's hard. Most people struggle to achieve this goal. And for many reasons, including inaccurate carb count, missed or late meal boluses, fear of hypoglycemia, exercise, fat and protein content of the meal. So these are all challenging. And currently the standard of care is to use just carb content of the meal to calculate pre-meal boluses. Based on both ISPAD and ADA guidelines, they recommend factoring protein and fat when you calculate pre-meal boluses. I would say probably ISPAD is a little bit ahead of the game comparing to ADA, but what ISPAD recommends, ISPAD guideline recommends, is actually impact of fat and protein should be considered in calculation of mealtime insulin dosing, because fat and protein can impact basically both early and delayed postprandial glucose levels. So we need to consider fat and protein when we calculate insulin dosing. And what they say is a conservative starting point is to add an additional 15% to 20% for high fat and high protein meals. What ADA, American Diabetes Association guideline recommends is that when you're having a mixed meal with fat and protein in addition to carbs, then the insulin dosing should not be just based on the carb content. But given these recommendations, how do we factor in protein and fat when we calculate insulin dosing? I would say in our clinics, I would say we really don't have clear guidelines on how we calculate insulin dosing for high fat and high protein meals. Here in this slide, briefly, I want to summarize how fat can impact glucose levels after food. So this is via several mechanisms, and many hormones are involved. But if what we want to summarize, what fat does basically is it increases insulin resistance. So you need more insulin for a high fat meal. It also increases glucose production in liver. It delays gastric emptying. It increases glucagon and also increases glucose formations. It's similar with protein too. Protein also impacts glucose levels after meals via cortisol, growth hormone, IGF-1, ghrelin. But the main reason for protein to increase blood sugar level is because it increases glucose formation. So basically about 75% of it will convert to glucose. So just to give you an idea, what do I mean by high fat and high protein meals? So here I have a couple of examples. For example, this is a spaghetti with meat sauce. This meal has about 28 grams of fat. We want to talk about steak. Steak can have about 48 grams of fat. And if you want to add French fries to it, this is about 20 grams. And salmon, if you want to look at salmon, it's about 30 grams of fat. We want to look at, different type of cheese, have different amount of protein, but a high protein cheese is ricotta, for example, 28 grams. But just to give you a context is that whenever we hear if we see on the menus in the restaurant, anything fried, anything that comes with some sort of sauce, like a creamy sauce, we need to think about, amount of fat that is added to that meal. For example, to make food also we use oil. So adding oil can add to the fat content. So these are, things that we can consider when we think about fat and protein content of the meal. So here, when I start actually with to giving you some background actually on some studies that I think they are key studies about how fat can impact post-meal blood sugars. This study, for example, was done in 2013 by Howard Wolpert, and I think this is one of the key studies in this field actually, that Howard and his group actually did a study using closed-loop system, and they looked at blood sugars 18 hours following dinner. So they compared two types of meal, a high-fat meal, about 60 grams of fat, and low-fat meal, 10 grams of fat. And they learned that high-fat dinners required more insulin. And this was about 42% comparing to low-fat dinners. And it caused high blood sugar. Here in the graph, you can see this is the time after basically they had dinner. It caused high blood sugars for about 5 to 10 hours after the meal. And this is probably longer than what we expect to see. This study looked at different protein content of the meal. So they basically compared low protein food. They started with about 12.5. They looked at 12.5 versus 25, 50 grams, 75 grams, and 100 grams of protein actually. And what they learned in this study is that protein does have a dose effect. So what does that mean? It means that if you have about at least 75 grams of protein, and we're talking this is about a protein only meal, so no carb and fat in this type of meal. But you need to have at least 75 grams of protein to see these high blood sugars after the meal. And this high can start at about 3 to 5 hours after the meal. This is an example of a study. I think this is also an important study was done by Bruce King in Australia, is that it was done in children. What I did, I'm a pediatric endocrinologist, and the other important piece in this is that most of these studies were done in adults. So we don't have a lot of studies in children because the impact can be different in children in different age groups. But this is one of the studies that was done in children, 33 children, and they compared actually low-fat, low-protein meal versus low-fat, high-protein meal, high-fat, low-protein meal, and a high-fat, high-protein meal. And this is important because we really can't look at just high-fat and high-protein meal, because the meal, when we talk about mixed meal, if you're having a large meal, it's usually high carb, high fat, and high protein. So we need to look at the effect of all these together, basically. So what they learned in this study, protein and fat have additive impact on the delayed post-meal rise. And the other important piece of this was that protein had a protective effect on low blood glucose. So protein prevented low blood glucose, and protein and fat both had an additive effect. So if you have a high fat, high protein, and you compare it with just high fat, you will see higher blood sugar with a high fat and high protein meal. So if we want to summarize what we talked so far about, is high fat meal reduces the initial post-meal blood glucose rise. High fat dinner requires more insulin and causes more high blood glucose. Protein has a protective effect on development of low blood glucose. And 75 grams or more of protein alone significantly increases post-meal blood glucose level for 3 to 5 hours. And protein and fat had an additive impact on the delayed post-meal high blood glucose. So this second set of the studies that I'm presenting here, we want to look at, okay, now we know high fat and high protein increases blood sugars after meal. How do we dose? Like, what are the dosing strategies? And Kristen Bell did actually several studies, and they came up with a guideline that published in Diabetes Care, actually. So for example, here, they compared high fat, high protein meal, which is blue line, with low fat, low protein meal, which is green line, actually. So we see that with a high fat, high protein meal, you see a higher blood sugar. And the other piece to it is higher blood sugar for a longer period of time. So they used an algorithm to control blood sugar, and they looked at the insulin dosing. And they learned that with a high fat and high protein meal, insulin was required, more insulin, about 65% more insulin was required. And the way it was given, it was a split dosing. So 30% of it was upfront, 70% over about 2.4 hours. Bruce King also did a study. This is in younger patients, actually. So they looked at combination in insulin bolus doses for high fat and high protein meal. This study is also important because it was done in children. And they compared different type of splits. For example, 30% upfront, 70% later, 40% versus 60%, 50% versus 50%, 60 versus 40, 70, and 30. In their study, they thought the most effective one was the one that they gave 60% upfront, so this line, and 40% later. And they learned that actually the high fat and high protein meal needed 60% more increase and more insulin. And the best way to do it is to give more 60% of it upfront versus 40%. If we want to see like all the other ones, like 30, 40, and 50%, you will see a late rise after. So the best one to handle was this one that was given, it was 60 versus 40%. This is a very also recent publication by this group in January, actually. So they looked at high fat and high protein breakfast. and to see how we can handle, like how much more insulin basically we need. And they learned that we need 140% insulin if we want to use carb ratio to basically handle this post-breakfast exertion if we're having a high fat and high protein breakfast. So here you see this is the red line. So 140% of the carb ratio was enough to manage this post-breakfast rise while avoiding low blood sugar. So if you want to summarize these past 3 studies, we learned that, by addition of 40 grams of fat and 27 grams of protein, that's how they defined a high fat, high protein meal, to 50 grams of carbs, the insulin requirement was about 65% more, plus minus 10% is always a range in the study. And they gave 30% upfront, 70% over 2.4 hours. In the second study, they thought, okay, they needed they learned that they need 60% more insulin and to avoid this late post-rise. And the third one, they added about 40% more to a high-fat, high-protein breakfast. The reason that I have this, so you see it is a range, but I think what all these studies are consistent is that we need more insulin and it needs to be given in split doses. But how do we calculate how much more insulin, like how many more units we need? Here I have listed several formulas that I'm not going through each. And what I want to just show is that it is complicated. Like carb counting is already hard. Like adding fat and protein to this formula, it is, doing a math problem before eating everything, it is complicated. So can we come up with something easier that works? So based on these studies, as I mentioned, Kristen Bell, they came up with these clinical guidelines recently. So what they came up with is, okay, if we want to look at fat content, and by adding 20 grams of fat to a meal that has some carbs in it, we will significantly reduce this post-meal glucose rise in the first 2 hours. So basically, we are delaying the peak glucose, but we will extend this rise for a longer period. So in the beginning, we will have some lower blood sugar than what we have comparing to a high carb meal, but there will be a delayed rise over 2 to 5 hours later. What they also came up in this guideline with is that type of fat had no impact on post-meal glucose. But I want to say there are studies that, came up with a different result. Like, for example, they compared, olive oil with avocado, with margarine, with butter, but this kind of stuff. But Kristen Bell, in their study, they came up with no difference in type of fat. So you just look at the fat content, not necessarily type of fat that you're having. But if you do have a significant amount of fat, then there is a dose-dependent effect. So what they suggested for a 20-gram fat meal, you can have a 75%, 25% split. So you give whatever you calculate for insulin based on your carb content, for your carb ratio, you give 75% upfront and 25% split over 1 hour and 15 minutes. If you're having a 40-gram fat meal, you give 65% upfront, 35% later. And if you are having more than that, like a 60-gram fat meal, you need more insulin. And they recommended about 20% more insulin and give 50% upfront and 50% over an extended period of time. So this is obviously when we talk about giving some it upfront and some of it over some period of time, more than 1 hour, definitely. We're talking about patients who manage their insulin with insulin pumps. As you know, insulin pumps, they have like this option, a standard bolus versus extended bolus. But how about patients who are on multiple daily injections? There was some idea like, what if we manage this post-meal rise with regular insulin instead of Humalog or Novolog? But studies have shown basically there's no benefit to cover fat protein meals with regular insulin in patients with type 1 diabetes. But what they recommended was that to give additional insulin bolus 1 hour after meal to match the delayed absorption. So this is what they showed. So the high fat and high protein meal is the red line, and it was given 1 extra dose after that. So this is how you can manage. So I want to talk about some practical tips that I've been using in my clinic. I recommend to my patient is that going over all this evidence and my personal experience in all of our studies and clinic patients, I consider like 30 gram as where you can start to consider a high fat meal. And when you think you have like a high fat meal, I think to start, we can start with a 30% increase. I think that's a safe place to start. And so whatever you calculate based on the carb content, to add 30%. And if you're on an insulin pump, I usually start with a 60% upfront and then the rest of it over 2 to 4 hours. And if you're on injection, it's the same concept. You increase 30%, you can give a 65% upfront and 35% of in 1 hour after the meal. These are some tips, basically. As I mentioned, the basic really doesn't change. We really need to discuss this with our nutritionist in diabetes clinic. It's a multidisciplinary work, it's a teamwork. So, and that doesn't change. Healthy dietary habits, having meal routines, this is what we learned. This is, there are more studies actually coming that, having routine, how it can help post-meal blood sugars. And the other piece to it that doesn't really change no matter what topic you're talking about is to optimize insulin dosing. So all the stuff that we're talking is that we consider this fact that the carb ratio and correction factor that you're using works for you. So all these are extra steps. So we want to make sure you're in touch with your diabetes team to optimize your ratios. And now that we are set with this part, how we can handle these post-meal rises. So as I mentioned, I start with a 30% increase to insulin carb ratio. And the other piece to it is people respond differently to high fat meals. A meal that's challenging for you might not necessarily be challenging for someone else with diabetes. So find the challenging meal for you and try one meal. You can, I think the other thing is it's good to start with a dinner because by making these adjustments for dinner time, and if a high fat and high protein dinner is the last meal of your day, then you will have enough time to look at your blood sugar to say, okay, if these adjustments to my dose work for me or not. Because for the most part, there will be no snacks after it, there will be no exercise after dinner. So you will have enough time to look at your blood sugars after making these adjustments to see, okay, if now I dosed my pizza with this amount of insulin based on this rule, did it work for me or not? If you're starting with 30%, and that's fine, that's perfect, you can continue doing that. But if that's not enough, you see a late rise later after midnight, for example, then this means next time you can go ahead with 40% and add extra insulin to that. So now the other last part of my talk, and actually which is the field that I'm working on, is how do closed loop systems handle these high blood sugars? Because in closed loop systems, we expect that, closed loop system is a combination of 3 main components: an insulin pump, a continuous glucose monitor, plus an algorithm that adjusts insulin dosing every 5 minutes based on the sensor data that comes to the system. So you would expect a closed loop system that's managing insulin dosing every 5 minutes to be able to handle a high fat meal because it's giving insulin every time a number comes into the system. So currently we do have 2 FDA approved closed loop systems in the market. I start with ControlIQ, and as you know, this is a quick background about it, that the target is 112.5 to 160. It increases basal rate if your predicted blood sugar is above 160 milligram per deciliter in the next 30 minutes. It does also give hourly corrections that's calculated at 60% of the recommended preset profile and your correction factor. The other closed loop system, 670G, that was approved in 2016, and the advanced closed loop system that is coming soon. But the difference is 670G has a set point of 120, and it does give, it does not give auto correction. So it's just a basal rate modulator, and the target that it uses for correction is 150. Versus advanced hybrid closed loop, which is a more advanced system, and you can have two different targets, 100 versus 120. It's more aggressive, so the target is 120, and it also does give automated boluses. But these systems are new. My point is that we really don't have enough information to say, okay, if these systems can handle. But my personal experience is that even in closed loop systems, having high fat and high protein meals are still a challenge. So at some point after midnight, when the system expects you to be sleeping, but that's when a high fat meal kicks in, and you will have a late rise. Are the systems aggressive enough to manage this late rise? And this is not. This is a graph of a ControlIQ download. I don't show this to share. Okay, if the system handles high fat or not, but the reason I have it, I want to show you how an extended bolus works in a closed loop system. So basically, currently, ControlIQ is the only closed loop system that has the option of an extended bolus. At this point, you can extend it only for 2 hours. This might change in future, but in other closed loop system, extended bolus is not an option. So if you want to use an extended bolus, you need to turn closed loop off. But in Tandem, you have an extended bolus option. So you can see this is a meal coverage and then an extended bolus over 2 hours after. So this is what you see. This is like a basal rate. You know, when there is an increase, this is an extended bolus option. So that's why I have it here. And the other this is very briefly about Loop, which is not, it's a do-it-yourself and it's not an FDA approved system. But I want to say Loop is the only one system that considers a dynamic carb profile. So basically, you can pick. It has 3 options: lollipop and sorry. So you can pick a lollipop versus taco and versus pizza. That basically it's based on the glycemic index, a low glycemic versus medium versus high. And actually it does adjust insulin delivery based on the glycemic index that you put in there. And it's more like a guidance because it does change if it sees that the rate of glucose change is different. So I want to say if this, even while using a closed loop system, I still recommend to my patients that the fact that high fat meals need more insulin doesn't change. So I still go with this recommendation: if 30 grams, at least 30% more insulin requirement. If you're using a closed loop system on a pump and you don't have an extended bolus, you can give a 60% upfront and like another dose later. You can make your extended bolus. But if extended bolus like ControlIQ is an option, go ahead and use extended bolus. I'm gonna end my talk at this point. I am ready to answer questions.
Awesome. Thank you so much, Laya. Yeah, I love the pizza. That's like the ultimate insulin. So we did have a few questions, which is great. And the first question was, is the post-meal spike target the same for all ages?
If you're asking about the ADA and ISPAT guidelines, yes, they have not, they don't have like different targets with different age group, but that's a good question, as I mentioned, especially as a pediatric endocrinologist. But so far, like all the data sets that I've been looking at, all the studies, I still go with the same target. Obviously, different algorithms might use different targets, but that's what I go with. Yeah.
Great. And then second question was, for someone with celiac, would that change the recommendations?
That's a great question. I mean, whenever I give this talk, I mean, there are many pieces that come to this talk having celiac for someone who is on low carb diet. Like, honestly, I want to say at this point, we really don't have the answer to any of these questions. But what I want to reinforce is that even besides this, diabetes is such a personal, I mean, you need really a personalized approach. So go ahead and see what works for you. So for someone who has celiac, and like if you eat like pizza that's gluten-free, see how that works for you. I mean, if you're wearing a CGM and you can follow these instructions and to see basically how this dosing works for you. It might work for you. Maybe even you don't need this, but I think if you think that this post pizza effect, we call it pizza effect, is a challenge for you, you should go ahead and start. So we really don't have specific guidelines for other categories, but I would say try and see if it works or not.
Yeah, it is definitely your diabetes science experiment. I think that was Ginger Vieira's book, and it really resonated with me because I think it's just very much a trial and error. And so the next question is, so when you split your extended bolus for fat and protein, let's see. You might have already answered this sort of with your last slides, but what if you're using a closed loop system like Loop where it's not an option, how to get the same effect? And I think you did say, sort of taking part of the bolus up front and then later.
And that is right. I mean, for Loop, I'm less worried, right? Because Loop is the only one that considers. But I want to say with other systems, the other thing about the closed loop system, it suspends insulin delivery when you're predicted to go low, right? So I'm less worried about this early hypoglycemia, right? This is the challenge with high fat meals. We know you need more insulin, but if we give more insulin, you drop earlier, you will have this rate rise, right? But with closed loop systems, since it does suspend insulin delivery, we call it like a super bolus. So I feel more comfortable to give a super bolus because I know the system can suspend and give more later when you need it.
Perfect.
Mm-hmm.
And then there's two questions about the 30% increase. So the first one is asking, 30% increase, is this from the carb content? And then the rest of that question is, what if you know how much protein and fat is in the food because it's like on a nutrition label?
Right. I mean, yeah. So, so the way I say, think about 30%. So for example, for a meal, if you need whatever you get based on the carb content, I mean, this can be an estimate, right? Because sometimes you learn, how much this food has, you don't necessarily look at the labels. But I want to say, if you think you need 10 units for that amount of carbs, and that meal is now a high fat meal, then add 30% to that. So 30% of 10 units is about 3 units. So add 3 units. But the point is, like, for a pizza, we teach our patients to count carbs, but you need more because you also need to cover fat and protein that comes into the pizza. But the way, the other piece of this question, like how do we consider, I think for fat and protein, I mean, I know this is really time consuming, it's complicated, but I think probably in the beginning, we need to look at nutrition labels to more. I mean, the other is for the homemade foods or like restaurants, obviously this is more complicated. Like even in the setting of our clinical trials that Marissa, you've been involved, like even when everything is supervised, we control everything, like we weigh, we look, but still we go wrong, like very, very wrong. I will have so many diabetes experts in doing the study, but still you make mistakes. And, but just to consider, it doesn't have to be really accurate, but like knowing that when you're cooking something, you use oil. So this is fat, it might not be obvious. That's what I'm trying to say. Yeah.
Yeah, I think that's a really good point. And I think too, yeah, knowing what you're putting into it is helpful. And yeah, we do a lot of wags where you're just trying to think about. And I tend to, for myself, I'm using ControlIQ, and so I do use the extended bolus feature, and I use it almost every time I eat out, just because I'm assuming that it has more fat than I put in my food at home. And it does its corrections, on either end if I miscalculated, which is nice.
Sorry, but that's what you mentioned. I mean, that's really nice about ControlIQ, that it does the correction. But a lot of times, I would say probably with most systems, these corrections are more challenging than preventing. So like preventing a high it's easier than chasing the highs to correct them. So all these strategies is for how we can prevent the highs.
Yeah, absolutely. And spend more time in range.
Mm-hmm.
So another question is, what if I eat mostly low carb? How do you bolus for protein and fat only? So, and they gave an example. So let's say you have dinner, salad, and broccoli. I would guess it was 10 to 15 grams of carbs. Is this considered a low fat, low protein, or high fat, high protein?
So that's an excellent question. But I want to say for protein, we know it's more dose effect. So that's why I think probably we can feel comfortable and say this is a low protein. But in terms of fat content, we need to consider that. And we hear that a lot actually with salmon is a common issue. So if because this is a low carb and a low protein meal, having fat, we talked about like how these components can be additive, but I would say if you don't feel comfortable with a 30% increase because you're not having carb and protein, you can start with a 15% increase, right? That's actually was the initial guideline in ISPAD. So they start with the 15 to 20%. So if you don't feel comfortable with a 30% increase, I mean, if you don't, so I would say probably 15 to 20% might be a, safe and conservative way to start.
That's a great idea.
Yeah.
I know. I find if I eat breakfast, for example, and I only eat eggs, I'll be high for hours. And if I add the piece of toast and bolus for it, I end up with much better blood sugars. It's really interesting.
I know, that's very interesting. Yeah.
Yeah. Anyway, so the other question, I have two more questions that have been typed in. So feel free to add any questions. We actually have a lot of people on this evening, so please feel free to ask. But the next question is, what about for exercise? So we know the closed loop has an exercise option, but still sometimes, have low blood sugars. And I actually personally experience this as well. And a couple of the questions are, doing less of a bolus for the meal beforehand. And then, oftentimes you can't use a temporary basal rate. You have to use the temp target.
So these are all excellent questions. I wish we had good answers for this. I mean, this question always comes up, right? It depends on many factors. Obviously, I think probably type of exercise and the timing of exercise, right? If you're having this exercise like after your meal, I'm assuming that's the case. That's a question that you're asking, but like how long after a meal, right? But obviously the first rule is that, you probably need to give less insulin because you are going into exercise. With exercise, I mean, we talk about fat and increasing insulin resistance, but exercise is the opposite effect, right? Because it increases your insulin sensitivity. So, but what type of exercise and how long exercise you do, I think these are all the questions that the answer is different. But the other piece is, you mentioned closed loop with exercise. I mean, it also depends what type of closed loop system you use, right? In Medtronic, it uses a different target. So what we recommend is that increasing the set point to 150 at least 1 hour before starting the exercise. I think this is a very important piece of it. It has to be done earlier. If you do it right before exercise, that's not going to work. In terms of ControlIQ, I want to say I've had patients that did not use exercise activity option at all, and they were fine. I've had patients that used it, but it didn't help. So the other way to handle is just turn closed loop off when you're going to start exercise. Use a temp base, because using a closed loop at the same time having a temp base is not possible. And that makes sense because a closed loop adjusts basal rate every 5 minutes. So if it doesn't let you use a temp basal, but if you want to use temp basal, what you can do is turn closed loop off and use a temp basal go. But I honestly think we need to try this if we're sure that the closed loop option does not help us. Like, I mean, if we're worried, then we should go not as our first step. So I start first with the closed loop. The other important part about closed loop I mentioned, I think this is a very basic, and I'm sure you know, but like in diabetes, when someone is diagnosed, we teach them, okay, have some carbs and go ahead and start exercise. But in closed loop, that's not true. That's a big no actually, because when you load yourself with a high amount of carbs, the system will see this rapid rise in your blood sugar, start loading you with insulin, and then you will crash later, right? So we want to avoid this rapid rise in the beginning. So I would say as long as your blood sugar is in a reasonable number, you should avoid having rapid acting carbs right before exercise. But I hope this answers your question. But I really don't know, like how, I mean, it just depends to many things to see like, okay, should I increase my insulin? Probably not. If you're going to go do exercise, you should not increase your insulin dose before your meal.
Yeah. I think it's also so hard. And I think that it would be nice if this were like a yes, no answer that we had for you, or even a cut and dry formula. But again, doing your own trial and error and just sort of seeing what works for you, I think is the most helpful. I have found that for me, for the ControlIQ, the exercise mode works for if I started early enough, if I haven't bolused right beforehand, and especially like if I'm going to be at a park for a few hours with my kids with sort of variable exercise levels, then I find it works pretty well. But when I'm doing really high intensity, sometimes I'll still need to treat with carbs. And that's just diabetes. I don't know. The game.
No, I mean, that's true. I mean, the 2 weak points of closed loop system are still exercise and meals, right? These are the two challenges that we have. Like, we can handle overnight blood sugars with no matter what system you do, but exercise is a big piece.
Yeah, and I think it's the changing of how sensitive you are to insulin, because it's not a static thing. It's a moving target, which makes it hard. But so there's a couple more questions. And one of them I don't want to forget is in the chat. So do you agree with a lower carb diet for children with keeping the 2-hour postprandial less than 140?
I do not, I mean, for pediatric populations, I do not advocate for low carb diet. I mean, children need carb. And I honestly don't also go with 140. I think that's also a challenge. And we increase the risk of hypoglycemia. In addition, the piece that children really need carbs to grow.
Yeah. For growth.
Yeah.
Just in general for growth. Yeah, I agree. And I think it's hard because I think, I understand, where parents are coming from and where people are coming from. If you eat less carbs, then, your blood sugars don't move as rapidly. And it is appealing in some ways. But I also think, sometimes when you're sort of too far on one end of the spectrum of something, that it just can be a little risky. Oh, and someone just said they couldn't understand the answer to low carb. So what she had said, and she'll say it again probably, is she didn't recommend low carb diet.
As a pediatric endocrinologist, I do not advocate for low carb diet to manage post-meal rise. And I think 140 is it's very aggressive to me. Like, it's we can't make that target, and that's okay. Children need carbs to grow. So we try our best. And there is highs and downs, but that's okay.
Yeah, exactly. It's more about, how often you're staying in that time in range. And that's what, the standards of care are moving to, which is really incredible. So there's a couple questions. One of them is, so essentially the 30% increase is sort of a guess, even though some food will have more or less fat and protein. So I guess, is there a way to sort of change it? Do you recommend, I thought one of them said doing 140 or 40% increase if it was really high fat.
So 30% is like, I think it's a good start point. But studies have shown that even you might need up to 65%. So, but I wouldn't go ahead and start with 65% increase. I think that's too aggressive. But so I start with 30%. If that doesn't work for you, then I start gradually go up, like then 35%, 40%, something like that. This is what I mean. Yeah, that might not work for everyone. Yeah.
And a lot of it is just practicing with the same food over and over. And it's funny, I have a diabetes educator friend who her husband really liked this like deep dish pizza, which is a lot of carbs and a lot of fat. And, he was determined and he just ate it a few different times, and did this different insulin calculations, different extended boluses. This was pre-closed loop, and he figured it out. And so, you can do this with your kids, as yourself, as a person with diabetes, and just figure out how to nail it.
I mean, that is an excellent example. Thank you so much, Marissa. But that's how they did these studies, and actually we plan to do a study similar. So like if you want to compare different patterns of boluses, when we talk about, okay, 30% upfront, 40% upfront, 50% upfront, or 60% upfront, this is how they do the studies. One person eat the same thing at the same time every single morning. And they give this, different dosing 5 days back to back, and they look at blood sugars and to see which one works. But, this is, I think was brought up earlier, but I would say, so yeah, in a closed loop system, if you're going ahead with 60% upfront, I feel comfortable because giving 60% upfront, but at the same time, more insulin dosing, the system will suspend insulin delivery if that's too much for you. So, but for the most part, I would say 70% was the one that causes more hypoglycemia. So that's why they went up to 60.
Yeah, I can't imagine doing 70% more. That sounds really scary. As just someone that has low blood sugars,
Yes.
And so there's one more question, and it's, have you found that duration of having type 1 throws a curveball? Because so this person was saying, I've had diabetes for 30 years, and he's had diabetes for more than double that. And he's found that, all the statistics don't apply.
That is an excellent point. Thank you so much for bringing this up. I would say I have seen only one study that when they were looking at different variables, type 1 diabetes duration was one variable that they looked at. And I think one piece to it that we really don't talk about, okay, we don't know about gastric emptying, the rate of gastric emptying when we have longer duration of type 1 diabetes. So this is the other thing. I mean, we don't really, I'm a pediatrician, so we really don't talk about gastroparesis at all. But that is a challenge too, right? I mean, then none of these formulas work for someone who does have gastroparesis, or like for someone with gastroparesis, even if, even without having a high fat meal, they need to consider a delayed gastric emptying and, trying to figure out how to avoid the low and then handle this late rise. So, unfortunately, yeah, this is also something needs to be studied, to have a good answer. But still, I think you need to figure out what works for you. And sometimes you can, sometimes you cannot. I mean, we do have patients that decided not to have like a certain type of meat because they tried different ways and it just didn't work for them.
Yeah, I don't eat Pop-Tarts anymore ever. Like there's just some foods that I'm like, it's just not worth it. Like maybe if you're really low. So there's another question about, are there studies for those of us that have long-term type 1 and slowed gastric emptying, and how would you participate?
So at this point, I'm not aware actually of any studies, but
Oh, we can't hear you again.
I'm saying like at this point, I'm not aware of any studies that are looking at this really endpoint.
Yeah, and in general, you can look at clinicaltrials.gov for studies that are being done, conducted in the United States, and you can see, where things are happening near you, or what studies are happening near you, or you could search, diabetes and gastric emptying and see if you could find something. I don't know of any either, but that's a great question, and it would be interesting even if we could collect like recorded data, like just from people who are living it and what they're with the meal boluses.
And I think now that when I started reading about all of this, and I'm actually in the process of designing my own trial, is that meal studies are general very, very challenging. And I'm sure, you deal with this every single day, a couple of times a day when you want to eat, when you're deciding about insulin dosing. But many confounding factors come in. As I mentioned, even when we're looking at these numbers in supervised settings, we see how many confounding factors that really prevent us from, coming up with a clean conclusion and guidelines. So, you want someone to have the same type of food every single day at the same time, but we want to make sure that person start having that type of food with a normal blood sugar. Like, what if they had exercise before? What did they had to treat a low before? Like, all this affects your blood sugars after you have your meal. Or like, you want to have snacks after your meal, you're going to have dessert after your meal, you're going to go do exercise after your meal. So these are all many things that come and impact blood sugars after your meal. So that's how challenging it is to studies, like to do studies like that. Or now adding like another piece, like long-term diabetes and gastro. These are all challenges with this type of clinical trials.
Yeah, and the other thing that I've been thinking about as we've been talking about this is, so my husband and we were really fortunate when we were dating. We went to Italy for a little trip, and the whole time I was drinking like red wine with my pasta and my pizza, right? And I don't typically eat a lot of pasta and pizza at home, especially like made out of white grains. Like we eat like lentil pasta, whatever. And I felt like, man, I'm like really giving my liver a run for its money. I should give it a break, switch to water. And my blood sugar went really high after I ate. And I was like, man, like I've been eating the same food this whole trip. What was I doing differently? And it's the alcohol for me. I find if I have anything that has alcohol in it, even if I need the insulin up front for if it has carbs in it, if I do an extended bolus, I will have more hypoglycemia. So it tends to act as my alcoholic extended bolus, which is like, and everybody's so different. But, for me, it's important for me to not do the longer boluses just to prevent that, so that when your liver's filtering it. Yeah.
Interesting.
It was just a funny way to find out that that's what it was. But yeah, that's something that that is another variable to add into it, right?
Sure.
Any kind of substances but in alcohol in particular, because of the delayed lowering effect. And I don't think, have there been any studies about alcohol in closed loops?
Oh, nothing close. Not that I am aware of. So
that would be a fun study. We could definitely recruit for that.
Yes, to add another confounding factor.
Yeah, I don't think you'd have trouble finding people to sign up. Yeah, and the other thing that I don't know if you know the answer to this or not, but one of the things that I've been reading a lot about and like learning about is sort of, age of onset of diagnosis, as well as being a contributing factor, and not in the sense of like disease process in general, but just sort of just because there's all these in-between types of diabetes. And it seems to me, and I don't know if this is true or not, that sometimes people who are diagnosed, later, like we have people that have LADA, and they don't have the same type of glycemic variability that, I was diagnosed at 2, and my blood sugars seem to just be, I have a lot of fun trying to keep it in that range. And I don't know if it's, I don't know if it's just differences in our bodies in general, or if it's related to the age of onset, but I wasn't sure if you had thoughts.
I wouldn't, I don't want to really add like Lada to this group, but I want to say like for type 1 diabetes, right? I mean, I guess this is the main difference, like when you're diagnosed much earlier comparing to adulthood. When we talk about your C-peptide level, right? And the chance of having a longer honeymoon and having some insulin on your own, like that really makes a huge difference in your insulin requirement
Right.
and how your pancreas, your own pancreas, will help adjusting and preventing this rise and avoiding these lows, right? That's, I think, a huge piece to this.
Yeah. I was just thinking about that when, the gentleman asked that question, because it could be related to gastric emptying. It could be related to complete lack of C-peptide compared to other people that with diabetes.
And are diagnosed much earlier.
Yeah, I think it's just a bag of a mixed bag.
For sure. Oops.
Well, thank you so much, Laya. I really appreciate your time. I think this was really helpful. We had about 50 people log in, which was great. So thank you everyone for your questions, and have a great night.
Thank you. Thank you so much again, Marissa, for giving this opportunity.
Yes, thank you.
Hope see you in the future.
Yes.
Bye.
Bye.